Hello, everybody. It's Neil Bentley here. We're just waiting on allowing more people to join. So I'll just put myself on mute until just after 12 o'clock. Hello, everybody. This is Neil Bentley. Can somebody just give me raise their hand just to confirm that you can hear me? Okay. Okay. Thanks. Thanks for that. If you lower your hands again now, that's brilliant. Okay. So good afternoon, everyone. And today we're going to cover two topics. I'm going to talk about the resurgence of whooping cough and just give us an update of where we are and what the disease is doing. And also, just at the end, due to the non-0157 E. coli issues in the UK at the moment, Mark Reed's going to give us a quick update of what ProLab Diagnostics is doing to aid that outbreak situation. So it looks like there's around 90, 95 to 100 people online already. So I think I'll kick off and just run you through where we are with whooping cough. Okay, and get my slides to work. Okay, so what causes whooping cough? Well, it's by two organisms, Bordetella pertussis and Bordetella parapertussis can cause a lesser disease, but it can still cause a whooping cough. It's a member of the genus Bordetella, and currently there's 16 species that have been known to cause infection in humans with pertussis and parapertussis being the main ones, and also bronchoseptica, which is mainly an animal pathogen, but it has caused disease in the in humans, and all the others have also, but to a lesser extent. So, as I said, pertussis and parapertussis can cause. It's termed pertussis disease. It's quite interesting when you try and search for anything online. Some people use the term whooping cough, others pertussis disease. So it's interesting how it changes, flicks between one and another. As I say, it's commonly termed whooping cough. And as I've said, parapertussis causes a milder disease normally. It's a small aerobic gram-negative encapsulated coccobacillus, usually seen singly in pairs, and it can exhibit bipolar staining. It's one of those bugs that we used to term gram-biguous coccobacillus. So the gram stain is quite difficult, and it doesn't do much other than grow on the agar. So the organism produces loads of virulence factors, including pertussis toxins, adolane cyclase, and tracheal toxins, and it's spread by airborne droplets through the coughing action, and it's thought to be more infectious than SARS-CoV-2, which is quite interesting. The incubation period is between 7 and 10 days, but it can go on to as much as 20 days. So it's quite a long time for it to be where it can be infectious, you can remain infectious for up to 5 weeks. Samples, you basically you can use a throat swab, but it's not ideal. But basically, you would use a nasopharyngeal swab or nasopharyngeal aspirate, which I'll go on to explain are quite difficult samples to get. It can be transported in Reagan-Low AMIs containing charcoal or universal transport medium, it should get to the lab within 48 hours of collection, hopefully a lot quicker than that. The bug grows on Bordeaux-Jonjou selective agar and also charcoal agar with cefalexin, which gets rid of the coliforms. You need to incubate for up to 5 days because it's a slow grower and also in a humid environment. Usually, I'm sure most of you know most of this anyway. Identification, you can use your traditional microbiology methods, also serological methods, molecular now, and also recently by the MALDI-TOF. Is a good way to identify all types of Bordetella. It is a hazard group 2 organism, but you are dealing with samples from the lower respiratory tract and sputum, etc. So you need to consider TB. So a lot of the times these samples are dealt with within containment level 3. And just to mention that an ongoing thing that I'll go through this, it's a vaccine preventable disease that we can halt if we wanted to. Okay, so now down to a little bit of history. It's the history is quite confusing. It's been around for a long time, and there's a lot of different accounts of when it was first seen. I've tried to work it through, but the earliest I've found is it was the term tussis vehementori, which means violent cough, was first described in a small boy in 1095 by Sir Grodric of Finchali, who interestingly was an English hermit that originated out of Norfolk and then went north. The term pertussis comes from the Latin word per, meaning much or excessive, and tussis meaning cough. A 15th century account gave numbers of newborn and young children deaths within the Persia area, and it was the French physician Guillaume de Balieu in 1578. There's a picture of him there, and he described, I'll read it through, its symptoms are severe, The lung is so irritated that every attempt to expel the cause of this distress can neither inhale nor exhale. The sufferer seems to swell up and, as if to strangle himself, holds his breath. So it's a horrid disease. And then it goes on into the 16th century. It was recorded in the Disease Bills of London of death in 1701, and it was first cultured. Bordetella pertussis was first cultured in 1906 by Belgian microbiologists Jules Bordet and Octave Genjou, hence the name of the Bordet-Genjou media. They then went on to identify the toxins it produces, which I'll go on to in a bit more detail later. A wholesale vaccine was developed by Lena Denmark, who was an American pediatrician in the 1930s. And interestingly, I found out that Lena went on to work until she was 103 years old, so was massively dedicated to the cause. Not sure I'll be there at 103. An acellular vaccine was developed in 1980, and this is less likely to produce the side effects which the initial vaccines did. There has been a lot of fear-mongering, vaccine-induced brain damage talked about, which was proved to be unrelated, and it lowered the vaccination rates in the 1970s, which caused 2 epidemics and 12 deaths in the UK. I think we probably all know about problems with vaccinations and scaremongering in the UK. And as of 2016, 5 multivalent vaccines are available within the UK. So that's just a brief history. So what disease does it cause? It causes pertussis disease and is widely known as whooping cough. Just recently, a lot of GPs are calling it the 100-day cough. Certainly the press have picked up on that. So you may see it termed 100-day cough. You get a prolonged paroxysmal cough with a characteristic whoop sound when gasping for air at the end of the coughing fit in some people. I know what this sounds like because my younger brother unfortunately caught whooping cough when he was 3 months old, and it's horrid. If you get a chance, just go online and put in whooping cough, and you can listen to the sound that it makes. It's pretty grim. So you get the catarrhal phase, which usually lasts from 7 to 10 days. But it does range from 14 to 21, and this after exposure to the bug within 1 and 2 weeks. You get your usual upper respiratory tract infections, a cough, a sore throat, rhinitis, malaise. So a lot of people just think they've got a cold. There's not usually a fever, and this is when it's most infectious, and you probably think that you've just got a common cold caused by rhinovirus or whatever. Coronavirus. And then it goes on to the paroxysmal stage, which is where most diagnoses are made. This is when you start to hear the whoop. This lasts between 1 and 6 weeks, but has been recorded for a longer length of time, up to 10 weeks. In this stage, you get difficulty in expelling thick mucus, causing rapid, violent, and uncontrolled coughing fits. The cough is clinically diagnostic with a short coughing burst followed by an inspiratory whoop, as I've already explained. It occurs frequently during the evening and night hours, and you can get up to 15 bouts in a 24-hour period. So it's quite full on. And you can also get post-tussive vomiting, which is quite common and which can cause a cyanosis in children. Adults may also experience sweating attacks, facial flushing, and rarely fainting due to the coughing episode. Coughing increases in the first 1 to 2 weeks and remains for the following 2 to 3 weeks, and then gradually reduces. There is usually no fever. in patients. The convalescent phase, which is the third phase, is 2 to 3 weeks of gradual improvement, but coughing fits can last for many months with subsequent respiratory infections. So if you get a common cold or something, it can all come back. Okay, so if you look at the diagram there, you can see how the symptoms progress week by week. You've got the stage 1, stage 2, and stage 3 that I've gone through. You can rarely get severe complications, including pneumonia, seizures, and encephalopathy due to these bugs. Death is infrequent and is usually in children who are unvaccinated. And I'll go on to that in a bit later on. Or in all ages with anyone with a serious underlying health condition, as we know. Many bugs can do that. Parapertussis can also cause a milder disease. And as I said, bronchoseptica is usually associated with animals, but can also cause a respiratory type disease. So when I started looking at virulence, I thought, well, I'm going to talk about all the toxins. However, this bug's been around for a long time, and it's had a lot of time to evolve to be better than us. And its virulent form today, it's had a lot of time to evolve. So there's lots of toxins, and I realised quickly that I could talk for a whole half hour about just the toxins. So I'm briefly going to brush over them, but I can talk more about them if anybody wants to in more detail. So the main ones are the pertussis toxin, which is only produced by Bordetella pertussis. It's an exotoxin with an A and B subunit, with the A unit involved with virulence and B involved with adhesion to the cell. There's adenylate cyclase toxin, and it's produced by all Bordetella species. It's a hemolysin and a cytotoxin. And then there's a whole host of other toxins, the tracheal toxin, paractin. I won't go down the whole list, but there's a whole list of toxins there that it can produce and cause pathogenic effects with. So how do we diagnose it? Sample timing is pretty important. You can culture usually within the first 2 weeks of starting to get the cough. It's not from the start of the disease, but start when you get the actual second stage of the disease. So culture within the first 2 weeks, or you can PCR up to 3 weeks and potentially up to a month. And also you can use serology, but I'll come on to that a bit later on. The type of swabs that you can get for culture and molecular per-nasal swab, nasopharyngeal aspirate, or a throat swab are okay, although a throat swab's not ideal. And samples for serology, obviously, are from blood and serum. The bug is strictly aerobic. You can culture it, PCR it, you can do serology. And for more details, I'd ask you to go and look at the UK SMIs, which are quite detailed in identification of Bordetella pertussis, and also a public health messaging in the investigation of whooping cough. So very, very good. And do remember that UK SMIs have moved from the UK HSA or old PHE website to the RC Path website. So the links are in there if you want to look at them. So I just thought I'd go back to taking a per-nasal swab. We're all pretty, think we're all pretty good at taking swabs now due to the coronavirus epidemic. And although a lot of the time people thought they were taking per-nasal swabs, they were actually just taking nose swabs. For anyone that's had a per-nasal swab done on them, it feels like the swab is actually embedding itself into your brain. I'm sure people that have had it, they know. And there's just a schematic of where the swab goes for a per-nasal swab. Note the bendy nature of the the shaft of the swab. They're usually a metal, a very thin metal shaft. And you can see here a per-nasal swab in that lady, and it's, as I say, it's more or less in the brain. It's pretty grim. Okay, so just talking a little bit now about pertussis culture. It's best within the first 2 weeks of cough, as we've already mentioned. It's a very delicate organism, and it dies quite easily. And it's a slow growth, so you need to incubate for up to 7 days aerobically in a moist atmosphere, as I've already said. Subculture, interestingly, only requires about 3 days. It's in a good environment, I guess, on the agar. Agars are very selective and give a high specificity of the bug, and give a smooth, convex, pearly, grey-white buttress colonies. I'm sure you've all seen them. Pertussis doesn't grow on McConkey and nutrient agar, and very poorly on blood agar. It's weakly oxidase positive, urease negative, non-motile, although lab adapted strains have been seen to be motile, so it doesn't do a lot really. It agglutinates with polyvalent antisera, but it may weakly agglutinate with parapertussis antisera, so be careful when you're looking at the antisera. Obviously, culture sensitivity is quite low, and the longer the illness has gone on, the less likely you're going to be able to grow the bug. Sensitivity is also dependent on the sample quality, age, patient, all the usual things, as you can expect. And a negative culture certainly does not exclude infection. We don't currently record antimicrobial resistance to this bug in the UK, and we don't normally do anti-susceptibility testing in the UK. But I'll come on to what drugs you can use a bit later. Macrolide resistance has been reported in some countries where they do AST. You must refer the culture to UKHSA Collindale for confirmation, serotyping, and further epidemiological studies. Currently, there are 3 serotypes known to cause disease: 1,2, 1,3, and 1,2,3, with type 1,3 being the predominant isolate in the UK. Just a quick description of the culture of the other Bordetella. So parapertussis is similar to pertussis, but larger, duller, and faster growing. It grows in 2 to 3 days. It also grows on nutrient agar, which is in sort of diagnostic, giving a brown discoloration of the agar. It's non-motile, oxidase negative, and urease positive. It does agglutinate with the parapertussis polyvalent serum, and very slowly, or not at all, with the pertussis antiserum. So again, be careful when you're doing the serology. Bronchoseptica is, as I said, usually an animal pathogen, grows well on media containing blood. It's quick growing, and it also grows well on McConkey. It's oxidase positive and motile, urease and nitrate positive, and that's one way you can differentiate it from pertussis. There are a number of other Bordetella species that I've already mentioned, and they're all identified in the standard methods that I messaged from UKHSA earlier. And you can differentiate all Bordetella species currently via MALDI. PCR, as with many bugs, it's more sensitive than culture. It will pick up dead and alive bugs, and you can get multiplex and monoplex forms of the PCR. The one on this screen, the picture is of a ProLab's ViaSure multiplex assay for Bordetella. It's only really suitable for patients in up to 4 weeks that have got when the bug is around. A nasopharyngeal swab is ideal, but you can use a throat swab if you need to. It's obviously very good for rapid diagnostics and for clinical sample management, and it enables speedy diagnosis and patient contact management, because you do need to isolate these patients. And it's also good for epidemiological studies. And you can also use WGS as we move into that world. So serology, it's not used so much nowadays, but it does have a place. It's helpful in diagnosing whooping cough in patients with a prolonged cough in 2 to 3 weeks. The ELISA can show a recent infection by looking for IgG, anti-pertussis toxin, and also anti-filamentous hemagglutinin IgG antibodies. It's not recommended in infants due to the immature immune system under 2 years old, and therefore it's only validated for over 2s. And it's obviously not fast because it requires a seroconversion of the patient. Also, vaccinated patients, recently vaccinated patients, and infection antibodies can't be distinguished by the ELISA, so you have to be very careful if somebody's been recently vaccinated. Okay, so treatment. So how do you treat this disease? Just check my watch. Okay, you treat symptoms for as you would a cold and flu, but also exclude the patient as soon as you start hearing the whoop. And you realise it's not just a normal cold. You'd exclude the patient from nursery, school, or work until you've given a course of antibiotics. Don't normally hospitalise patients, but you do if obviously if they've got breathing difficulties. But there's a low threshold admitting children under 6 months because it can cause a horrendous disease. You need to isolate the patients. Admissions, not necessary. An onset of cough within 21 days, you need to prescribe antibiotics. First line is macrolide. For infants under 1 month, clarithromycin is preferred, and children to adults, either azithromycin or clarithromycin. And for a pregnant woman, you would use erythromycin. If macrolides are contradicted, you should prescribe cotrimoxazole, but these are not suitable for newborns and pregnant women. Make sure that if there's any outstanding vaccinations that they're given, and any contact should be offered prophylactic antibiotics within 21 days. And if in a vulnerable group or healthcare workers, they should perhaps be given vaccination as well. So, as I've already said, it's a vaccine preventable disease, and that remains the best defense. Children that are vaccinated have an 84% less likely chance to get the disease. And vaccine efficacy does decline after a couple of years. However, most deaths are seen in neonates, so it's important to get these kids vaccinated early. In UK, there's 2 vaccines that are part of combination vaccines that are used in the UK. And also pregnant women are offered the vaccine at 20 to 32 weeks to protect the mother and the baby, with babies vaccinated by 3 doses, 8, 12 and 16 weeks, and then offered a preschool vaccination at 3 years, 4 months. And in the US, interestingly, they provide another booster for 11 to 12-year-olds, but we don't do that in the UK. And it's not recommended for healthy children over 10 years old in the UK. As I've said, the JVC recommend healthcare workers with direct contact or with vulnerable groups should be offered a booster. And vaccine hesitancy is a major concern with this disease. So just very, very quickly go through some epidemiology. We're currently going through an outbreak in the UK. There's up until Jan to April this year, we've seen just under 5,000 cases with 8 reported deaths during that period of time. That compares with a total of 858 cases in 2023. So we are seeing a spike at the moment. And you can see those from the graphs. It is a cyclical disease, peaking in every 3 to 5 years. with the last peak in 2016, where there was almost 6,000 cases in the UK. So we're getting pretty close to that now. In fact, I think we've probably passed it now. And since the maternal vaccine program was initiated in 2013, there have been 29 deaths from babies confirmed with pertussis Ds in the UK. And sadly, 23 of these were from mothers not vaccinated during pregnancy. So you can see the importance of vaccination. And this is just showing the rise in the UK. So this is week the 2nd to the 8th of June, week 23, and you can see a rise in people visiting the GPs with whooping cough. You can see the rates going up, and in graph A and graph B, that's in the age by years, and you can see it going up in all age groups, and also in all areas of the country in graph C. So it's shown we're going through a problem at the moment. So looking further afield on a global perspective, there's some conflicting data here, and it's probably because data is not up to date and it's not considered as an important disease as perhaps some of the other diseases, wrongly so in my opinion. The WHO estimates that there's been 151,000 cases of whooping cough each year. That was data from 2018, with around just under 90,000 deaths. But the latest data is from 2008. A more recent study cited by the CDC estimate it to be in the region of 24 million cases and just under 161,000 deaths. So they're quite different sets of data there. And looking at the zero-dose children in the world, it's estimated that some 14.3 million kids in the UK are unvaccinated. Of the vaccinated children that have had all 3 doses, 84% are vaccinated with all 4 doses. So of the vaccinated population, it's a good figure. Global pregnant women vaccine uptake is thought to be around 46%, and in the UK it is as low as 58% in 2023, which is surprisingly, and within the Greater London it's really low, down at 36%. And just as interesting stat here, the WHO estimate that over 5 million deaths in the children under 5 years old are from preventable causes, and vaccine preventable disease are included as a large part of that group. So sorry about this graph being quite busy. You can see for the different regions in the world, you'll have this graph as part of the presentation, but so you can look in more detail. But you can see that the number of cases are going up. And interestingly, if you look at the European cases, they're going up, and also the incidence per million people in the UK is got a sharp incline there. You can see that, and that's from WHO data. And then just a quick update on the vaccine uptake of 1-year-olds globally. You can see from the map there the areas of the world where vaccine uptake is and percentage rates on the left-hand side. Interestingly, there's places like South Korea, 98%. UK 94, 92%, US 94%. So there's rates around the UK. And if you look, North Korea is at 0%. They don't vaccinate anyone. And just to show you the current pertussis cases, the latest reported data was 2022, and you can see that there's a massive outbreak in China and Australia and New Guinea and New Zealand. And interestingly, if you look at that data, just can't get the get my I got just underneath China. You can see North and South Korea. I can't show you on the map because I can't get my pointer to work. But North Korea is right next to where there's a massive outbreak where they don't vaccinate anyone, whereas in South Korea they do 98%. So it'd be interesting to get the stats from that country, but I don't suppose we'll ever see that. So some WHO guidelines. They're usually not just around pertussis. They're around vaccination of a number of diseases, and there's a you need to prevent this through vaccination. There's the 2011 to 20 Global Vaccination Action Plan, which is ongoing, and there's immunisation programme data from 2022, which is showing the rates around the globe. You can have a look at. There's also child health initiatives, newborn health initiatives, and 24th to 30th of April 2024 was World Immunisation Week, and hopefully that will carry on year by year. But the WHO's overriding advice is to vaccinate, as I've mentioned there. So just in the press, the BBC and even the Financial Times are indicating that we've got a problem in the UK. And also you can see it in the BMJ where they say whooping cough rises sharply in the UK and Europe, and the Royal College of Midwives health leaders issue urgent advice as cases of whooping cough rise. And then there's more press reports there. And then even the Daily Mail glorifies it as usual. Terrifying 100-day cough sweeping through Britain. Urgent warning over whooping coughs cases spike a decade high. Telling people to get vaccinated. Okay, and just to finish off, this is a graph of whooping cough deaths by age between 1990 and 2019, and you can see that the majority of people affected deaths are in under 5-year-olds. Okay, so we can basically, my message here is we can stop this to the patient with whooping cough by vaccination. Okay, and just one last thing, get vaccinated and don't leave it to chance. I'll now pass over to Mark Reed, who's going to talk to you a little bit about the non-0157 E. coli outbreak, and then after that we'll do some questions. Thank you, Mark. Over to you.
Okay, thanks very much, Ed. A fantastic presentation as usual. Thank you. I'm sure everybody enjoyed that. I'm certainly not going to try to follow with that level of detail. I was just asked that a number of people who I know are on the call have already been in discussion with us about the non-0157 issue that's going on. Just so you're aware, we are in direct contact with the E. coli reference centre in Scotland, also in the UK through UK HSA. The 5 sites that are doing the reference work. Help me out here, Neil. So we've got Bristol, Manchester,
Cambridge,
Newcastle,
Leeds, Newcastle,
Cambridge and Leeds. Yeah, so they're certainly doing most of the work at the moment, and there
Birmingham.
is
Birmingham. Yeah. Sorry, Birmingham.
Yeah. Okay. And there is a little bit of a drive. There's a push coming from UK HSA, I think, to actually sort of have the testing done regionally. So just so you know, the products are available. Okay, there is messages going out with full technical details. If you need something, just drop us a message or put something to the chat here. We do a kit which covers 026, 045, 0103, 0111, 0121, 0145, and of course the 0157 itself. 26 and 145 certainly seem to be the ones which are causing most of the issues, and they are all available as single reagents as well. Okay, so that was it really. I thought I'd sort of take that opportunity. Great talk again, Neil. We're not quite sure what the next topic's going to be, but if anybody has any requests or suggestions, Neil knows everything, so you can ask him to talk about anything. And I think, Anne, were you going to take some questions or do something with questions? Are you there, Anne?
Yeah,
Yeah.
I'll just yeah. So thanks for the questions.
Okay.
Just to let you know, we have now organised the next webinar, and we're lucky enough to have Angela Douglas and Nick Brown, consultant microbiologist at Cambridge, talking to us about the AMR 5-year plan, both the policy side of it and also the clinical and technical side of it. So it's a must attend event, and that is end of July. I think it's the 30th of July, but we will send information out to that. So anyway, over to Anne. Anne, are there any questions?
Yeah, we've had one come in from Susan in Borders, who's asked what drives the cyclical aspect of outbreaks.
Well, who knows? I would say it's the rise is due to at the moment is due to vaccination coverage. There's a lot of people not getting vaccinated where they used to be. We've got a lot of people coming to the UK that perhaps haven't had the opportunity to be vaccinated, that are keeping it kicking. But why it occurs every 3 to 4 years, I couldn't find any information as to why that actually happens. It's just a known thing. So I'm sorry I can't give any more detail on that. I will look into it a bit more, but I haven't found anything yet, unless anybody else knows, of course. Any others, Anne?
Stacey from Grampians just asked, if the drive is to vaccinate, then why would the UK not offer the booster to over 10-year-olds?
Yeah, I think that's maybe a question that we could maybe pose to JCVI, and I'm sure they've got their reasoning and also nice. But as I say, in the States, they decided to vaccinate. I guess it's because the vaccine only really lasts for a couple of years before it starts to wane. So they're wondering what the economic value is, although its importance, to vaccinate in neonates and pregnant mums is, that's where it's killing people under 5 years of age, or generally under 6 months of age, the majority. So, but why we're not vaccinating at school years, I don't know. Perhaps it's financial.
The questions are coming in thick and fast now, Neil. Are you ready?
Yeah, go on.
Gareth has asked, are there any long-term complications of whooping cough?
Not that I've seen, other than it lasts. It's called a 100-day cough for a reason. It lasts for a long time, the acute illness, and then you can go on to have really bad coughing fits if you have a subsequent cold within the next year or so, a rhinovirus, or one of the many coronaviruses that cause coughs, or any other coughs and cold organisms. So that's all I've found.
Tariq has asked, is there any evidence of asymptomatic carriage?
I haven't noticed any, but I guess there will be. Certainly, within the first couple of weeks, if you go, it's just known as a normal cough. Not everybody has the whoop cough and really bad coughing fits. So a lot of people may think that they've just got a normal cough, a normal cold. So I'm guessing there is asymptomatic carriage, but I haven't seen any data on that at all.
Ella has asked, how do you feel about the new UK HSA guidance, which is now recommending treatment and exclusion for most individuals not in priority groups? Is this namely a resource-based decision?
Yeah, I guess so. Yeah,
Got to stay impartial with these things, haven't we?
I do. Yeah. It's particularly as I used to be UK HSA. So, but yes, I mean, we do the best we can with what we've got, and I think the guidance is good, and also the identification with the standard method is good, and I implore you all to read that if you can. Yeah. Any more, Anne?
Just a quick comment from Rui Siddiqui, who said that she's very happy to see that the UK SMIs raised in your talk, and like to invite everyone on the call to engage with the UK SMI sent out for public consultation.
Rui, good to speak to you again, although by a third party. So the importance of the SMIs, they're dead important, and we can all have a massive impact into their revision, and if any new ones come along, how they're compiled. So I advise any budding microbiologists to make sure that they understand about the SMIs and also get on the mailing list, so you can comment on any new SMI or updated SMI that comes out. It's my public health bit for Rui. Okay.
I think that's all I can see. Yeah.
Okay. Well, thank you very much. And we've gone on, I've rambled on a little bit. Hopefully you've got time to grab a sandwich, but make sure it's in a sandwich from a reputable firm, and it's not a non-0157 type sandwich. So on that note, I will leave you and look forward to catching up with you at the next time. Okay, goodbye everyone.